Dear student, my name is Dr. Ahmed Al-Hamshari. I am a lecturer of otolaryngology, head and neck surgery in Toronto University. I will present to you today a lecture on otosclerosis and inner ear diseases. So first of all, otosclerosis is a disease of bony labyrinth in which is characterized by formation of newly vascularized spongy bone, and this replaces the compact bone of the bony labyrinth. And you could clearly see on the picture on the right hand side how the spongy bone looks like in the footplate of the stapes compared to the compact bone on the left side of the diagram. We have 5 different types of otosclerosis. So the first type in which there is anterior focus, second type in which there is a posterior focus, and the third type in which there is a circumferential focus, and the biscuit type in which there is a very thin foot plate, and the obliterative type is the most aggressive type in which there is otosclerotic focus completely covering the foot plate of the stapes. The etiology of the otosclerosis is largely unknown. However, there are 3 different theories explaining this disease. First of all is the genetic predisposition. As this disease runs in families, that's why there is a genetic background predisposing to this disease. And the second theory is a developmental theory, which explains the otosclerosis as an otosclerotic focus replaces the cartilaginous cell rest of the otic capsule. The third theory is the enzymatic theory, which explains the otosclerosis as the otosclerotic focus is normally formed by action of lysosomal hydrolase enzyme released from histiocytes and osteoclasts. Clinically, there are 3 different types of otosclerosis. So the first type is the stapedial otosclerosis, which is the commonest type, which causes conductive hearing loss. Second type of otosclerosis is the cochlear otosclerosis, which is the rarest type, and this type causes sensorineural hearing loss. And the last type is the mixed or combined otosclerosis, which causes mixed hearing loss. The incidence of otosclerosis is surprising because this disease is more common in females than males, and this age is quite common to start in middle age group, usually between 20 and 40 years old, and there is positive family history of this disease in 50% of the patient. And the most characteristic features of this disease, as it happens more commonly in females, that it usually starts or it increases or gets aggravated during pregnancy. The otosclerosis as a clinical picture usually present with bilateral progressive hearing loss, and in many cases the patient develops tinnitus due to the hearing loss. And one of the characteristic symptoms for otosclerosis is what we call paracusis wilchi. And paracusis wilchi means this patient hears better in noisy environment compares to quiet environment, and this is largely due to the loud voice used by the speakers in loud environment to overcome the background noise. The signs of otosclerosis, those patients are normally having normal tympanic membrane shape and mobility. And when it comes to tuning fork test, in stapedial otosclerosis, we normally find bilateral conductive hearing loss, which is the commonest finding. However, in cochlear otosclerosis, this patient normally present with pure sensorineural hearing loss, and in mixed otosclerosis, this patient should normally having mixed hearing loss. Schwartz sign is one of the characteristic signs for otosclerosis, in which there is a flamingo red tinge seen through the tympanic membrane due to active otosclerotic focus over the promontory of the inner ear. The differential diagnosis of otosclerosis is very important because we have to differentiate the otosclerosis from the other causes of conductive hearing loss with intact tympanic membrane. This question is usually preferred by many of our staff members in both on oral exams and in end-round exams. So the commonest causes of conductive hearing loss with intact tympanic membrane, first of all, is otosclerosis. Second would be otitis media with effusion, and middle ear atelectasis, and adhesive otitis media, tympanosclerosis, ossicular disconnection or disruption, and ossicular fixation. In terms of investigation for the otosclerosis, the audiological evaluation, normally the pure tone audiometry will reveal either conductive, mixed, or sensorineural hearing loss, and the tympanometry in most cases will reveal type AS instabilial otosclerosis, and the stapedial reflex is mostly lost in stapedial otosclerosis. When it comes to treatment, there are three main lines of treatment for otosclerosis. The first line of treatment would be stapedectomy, and this is the preferred option for stapedial and combined otosclerosis, in which we will remove the stapes, head, neck, and two crura, and we will normally create a hole through the stapes foot plate, and we put in artificial prosthesis as a Teflon piston or fat and wire to replace the immobile stapes. And the second option would be hearing aids or cochlear implant, which is the preferred option for cochlear otosclerosis and other types of otosclerosis. And this option is preferred if the patient refuses the surgery, or the surgery has failed, or in the only hearing ear situation. Last option would be medical treatment in form of sodium fluoride and vitamin D, and we normally prefer this option for active and cochlear otosclerosis. And we got some diagrams to demonstrate how we do this stapedectomy surgery. You could clearly see in these diagrams over there on the top end where is the otosclerotic focus affecting the mobility of the stapes foot plate, and then we remove the head and neck and the two crura of the foot plate, and we create a hole in the stapes foot plate, and normally we put in the artificial prosthesis, and we attach the top end of the prosthesis to the long process of incus, and we normally test the mobility of the Teflon piston after insertion. And you could clearly see here how we do it in terms of incision. We normally do an incision on the posterior canal wall as an end oral incision, and we elevate the tympanomeatal flap, which is a flap of the posterior canal wall, and the tympanic membrane, and then you will get to see the long process of incus with its articulation with the stapes head, and after that we disarticulate the stapes head from the longer process of incus, and we remove the head, neck, and two crura, which is a stapes superstructure, and then we will insert Teflon piston prosthesis after creating a hole in the foot plate of the stapes. And you could correlate in this diagram the difference between the left side, in which is the normal stapes foot plate, and the right side, which is the side after removal of the stapes superstructure and the insertion of the Teflon piston. And in these diagrams also as well, as the tympanic membrane is elevated, the tympanomeatal flap is elevated, and then we will remove the two stapes crura and the head and neck, and we'll create a hole, and we will insert the Teflon piston prosthesis, and we will attach the top end to the longer process of incus, and then we will replace again the tympanomeatal flap to close the external auditory canal. The second part of our lecture today will be about inner ear diseases. Before we start the inner ear diseases, we need to have a quick idea about the anatomy of the inner ear. Anatomy of the inner ear is composed of two parts. First part is the membranous labyrinth, which is a chain of connected ducts and sacs, and this membranous labyrinth is surrounded by a bony labyrinth, which are a chain of bony canals and bony dilatations. So the membranous labyrinth, to summarize, is composed of three main different parts. The first main part is the membranous cochlear duct, which contains the organ of Corti, which is the sensory end organ for hearing, and the membranous semicircular canals, which is the superior, posterior, and lateral semicircular canals, as you see here in these diagrams. Here is the lateral, and here is the superior and posterior, which have a common crus. And at the one end of the semicircular canals, there is dilation called the ampulla, and this ampulla contains the sensory end organs for semicircular canals, which is the cristae, while the electrical and saccules are saccular dilatation here, which are contained within the bony vestibule, and both of them contain the sensory end organs for the electrical and saccule, which is called the macula. The pony labyrinth is composed of the pony cochlea, which is a coiled canal, 2.5 turns, which normally contains the cochlear duct and the sensory end organ for the hearing, and the three semicircular canals, lateral, posterior, and superior semicircular canals, which contains the three membranous semicircular canals, and the pony vestibule, which contains the utricle and saccule. To understand the cochlea, we need to make like a cut section in the cochlea, in the bony cochlea first, which reveals it's a coiled canal, 2.5 turns as we see, and if we magnify one of these canal transections, we will find three different compartments. So there is middle compartment and there's upper and lower compartment. The upper and lower compartment, the upper compartment called scala vestibuli, lower compartment called scala tympani, and both of them are filled with perilymph and communicating with each other, while the middle compartment called a fluid called endolymph and contains the organ of Corti. And if we magnify the organ of Corti more and more, we'll get to see here is the organ of Corti, which is sitting on the basilar membrane, and here you could clearly see the hair cells arising from the top end of the organ of Corti, which vibrates with any vibration inside the endolymph. Any fluid vibration inside the endolymph will cause these hair cells to move or to vibrate. Vibration of these hair cells will produce electrical impulses along the cochlear nerve ending. And if we need to quickly understand the physiology of the hearing, so first of all, there is a mechanical sound waves which will be transmitted through the drum and the ossicle to make a vibration in the stapes foot plate, which will in turn produce a vibration within the cochlear fluid, within the perilymph and endolymph. So this vibration within the perilymph and endolymph will be transmitted as electrical impulses along the cochlear nerve ducts to the hearing cortex, to the auditory cortex. And when it comes to physiology of equilibrium, so physiology of equilibrium is three-staged process. So first stage would be that the sensory input or the sensory information coming from vestibular part of the inner ear, which is responsible for maintaining equilibrium during head movement, and this is composed of the three semicircular canals and the otolith organs, which are the utricle and saccule. And the second part from which the brain receives sensory information about the body balance or body equilibrium is the eye, and this last sensory organ which gives an idea about the body balance would be the proprioceptors of the muscles, joint, and tendons. And the brain later on integrates this sensory information and sends the motor orders to both extraocular muscles to keep the eye stable and the spinal muscles to keep this limb and trunk stable. And this diagram clearly summarizes the three-staged process. So needed to receive an input from vestibular system, from eye, and from proprioceptors, and then the brain will integrate them in cerebral cortex and brainstem and cerebellum, and will give an orders to both extraocular muscles and spinal muscles to maintain the body positioning. A vestibular apparatus is composed of three semicircular canals, which are stimulated by angular head movement, which is the rotation, and utricle and saccule, which are stimulated by linear head movement, and the vestibular nerve and the nuclei. And you could clearly see in these diagrams, here is the saccule, here is the utricle, and here is the three semicircular canals, the lateral one, and the superior and the posterior semicircular canal. And these canals are normally perpendicular to each other in orientation, as is clearly seen in this diagram. Semicircular canals are fluid-filled canals, and there is dilated end, as we have said before, called the ampulla. The ampulla contains the sensory end organs of the sensory hair cells, called the cristae, and which is covered by gelatinous material called the copula. And you could clearly see in these diagrams, here is the sensory end organs in the dilated end, and you could clearly see here, here is the cristia, here is the sensory end organ, and here is the copula, which normally moves right and left with the different direction. And in the second diagram, you see here is the acceleration or the rotation of the head, and if you got the rotation that way, the movement of the fluid will be in the opposite direction, and this movement of the fluid inside the semicircular canal will stimulate the copulae to move. Once the copulae move, it will cause movement of the hair cells. Movement of the hair cells will produce electrical impulses along the vestibular nerve ending. When it comes to utricle and sacules, utricle is vertically oriented while sacule is horizontally oriented, and the orientation of both sensory end organs will allow them to detect linear head movement, which is acceleration and deceleration. And the utricle and sacules contain the sensory end organs, which called maculae, and maculae having sensory hair cells on the top end. Movement of fluid during head movement will allow movement of this hair cells. Movement of these hair cells again will produce electrical impulses which will be transmitted along the vestibular nerve ending. Hair cells are covered by a membrane called otolithic membrane. So to summarize how the stimulation of the vestibular system happens, so first of all, motion happens in forms of in different velocities and acceleration. So when it comes to angular head movement or angular fashion or rotation, so the head acceleration or deceleration in rotation will stimulate the fluid inside the semicircular canal to move as it is oriented in different angles to each other, and this kind of stimulation to one of the semicircular canal and inhibition of the other will allow the brain to detect the direction and the side of the rotation. While head acceleration or deceleration in linear direction will stimulate the maculae in utricle and saccule and will allow the brain by detection of stimulation on one side and inhibition on the other side, or stimulation of one of the end organs and inhibition of the other will allow the brain to detect the side and the direction of the linear movement. And mechanism of stimulation: deflection of the stereocilia or the hair cells towards the kinocilium, which is the largest hair cell, will cause stimulation, while deflection of the stereocilia, which is the small hair cells, away from the kinocilium, which is the largest hair cell, will cause inhibition. And you could clearly see here the stereocilia and the kinocilium. If with angular head movement, there is movement of fluid inside the semicircular canal. Okay, if it's away, then the stereocilium will move away from the kinocilium, and this will cause inhibition. While if in the other direction, the stereocilium will move towards the kinocilium, and this will cause stimulation. The same happens with the utricle and saccule, in which there is here's the head tilt and here's the head straight. If the hair is straight, the stereocilium will move away from the kinocilium, and if the head is tilted, then the stereocilium will move towards the kinocilium, causing the stimulation of the macula and the macula in the utricle and saccule. Then the diseases of the inner ear diseases, the commonest one is congenital dysplasias, which is called the Mondoni dysplasia. Sorry for inconvenience. Okay. So the Mondini dysplasia is a single turn of single turn inside the cochlea, and it is the commonest congenital anomaly in the inner ear. And in Mondini's dysplasia, we normally prefer to do cochlear implant nowadays. In old days, we used to give them hearing aids. And the second topic is the labyrinthitis, in which there are different causes for labyrinthitis. It's the viral labyrinthitis, which may be caused by Mumps virus or herpes virus, bacterial labyrinthitis as a complication of meningitis or as a complication of chronic suppurative otitis media, and toxic meningitis, which happens with ototoxic drugs. Types of labyrinthitis: there is tympanogenic type, which happens as a complication of chronic suppurative otitis media, meningeal type, which happens with otosclerosis, and toxic type. Clinical pictures of labyrinthitis is sensorineural hearing loss, tinnitus, and vertigo, disequilibrium, and nystagmus. Treatment of labyrinthitis, if it's tympanogenic labyrinthitis, is antibiotic and surgery, and if it is corticosteroid, if it's viral or toxic type. Ototoxic drugs, this is a very important item. In old days, some of the doctors used to use streptomycin and gentamicin to treat especially pediatric infections, and they are well known for very vestibular toxicity. And some of them has used amikacin to treat some chest infections, which causes cochlear toxicity. We still till now using cisplatin in cancer patient as a chemotherapy, and this drug is well known for its ototoxicity, while in some Western countries they started to use the monoclonal antibodies as an alternative to cisplatin in chemotherapy, but still being used widely both in developed and in developing countries. Loop diuretics are still widely used while still known for their ototoxicity, and the most famous one is Lasix. Quinine drug is still used in cardiology, and salicylate has been in large doses above 5 grams per day, which is not currently used nowadays in such large doses. So vestibular neuronitis is causes unknown. It might be viral following common cold, which is the commonest reason, might be vascular, metabolic, or mechanical. The clinical picture of vestibular neuronitis is that patient develops sudden onset of continuous severe vertigo, which is exacerbated by changes in head positioning. The vestibular neuronitis diagnosis is we diagnose them as the patient having horizontal or rotatory nystagmus. By caloric test, the patient will have hypo or non-functioning vestibular apparatus. Treatment will be bed rest in dark room, just corticosteroids, IV fluids, and antivertiginous drugs, either IV or suppositories, because of decreased oral intake. Traumatic conditions, there are so many conditions. Most famous one is the fractured temporal bone, noise trauma, perilimb fistula, surgical trauma, radiation injury, and inner ear paratrauma. Temporal bone fracture is the commonest inner ear trauma, and we classify them according to their orientation or relation to the longitudinal axis of the temporal bone, to longitudinal fracture and transverse fracture. So the longitudinal one is the most common one with 80% incidence, while the transverse is 20% in incidence. So longitudinal temporal bone fracture normally happens due to parietal or temporal blow, while transverse fracture happens with forehead or frontal blow or occipital blow. Longitudinal fractures normally courses through external middle ear and mastoid antrum, but it doesn't pass, the fracture line doesn't pass through the inner ear or doesn't pass through the facial nerve. That's why it's having very rare incidence of sensory neural or facial nerve. While the transverse temporal bone fracture normally cuts through the inner ear and the facial nerve. That's why it's having a higher incidence of facial nerve palsy and sensory neural hearing loss and severe vertigo, while it avoids the course of the middle and inner ear. That's why it doesn't cause any conductive hearing loss. Okay, so you could clearly see in this image where is the blue coming from, parietal or temporal blue. This longitudinal temporal bone fracture, it passes through the external ear and middle ear, but it avoids the inner ear and the facial nerve, which is here. While the transverse fracture line, it passes through the inner ear and it cuts through the facial nerve, and it happens with occipital or frontal blow. So longitudinal one, in which the fracture line is parallel to the longitudinal axis of the petrous apex, it passes through external tympanic membrane and middle ear. That's why ear discharge is common, because commonly there is a tympanic membrane perforation or tears, and the fracture line passing through the middle ear will allow blood and CSF to come from the external district canal, so there is bloody and CSF discharge. And conductive hearing loss is quite common, ruptured drum with ossicular disruption, and very rarely this patient will have facial palsy or sensory hearing loss. And you could clearly see in the CT scan, this is longitudinal temporal bone fracture passing through the mastoid antrum and through the middle ear. Transverse temporal bone fracture, the fracture line is perpendicular to the longitudinal axis of the petrous apex, and fracture line passes through the inner ear. That's why this patient having severe sensorineural vertigo and tinnitus. Some of them, due to the fracture line passing through the inner ear, might have a hemotympanum or CSF autorhinuria, with the CSF collecting in the middle ear, then passing through the Eustachian tube to the nose. That's why it comes out from the nose. That's why it's called CSF autorhinuria, and this might cause conductive hearing loss. 50% incidence of visual nerve palsy, and here you could clearly see the fracture line, and in the CT scan you could see the fracture line passing through the cochlea. So this table will clearly differentiate between both types. with higher incidence for the longitudinal compared to the transverse. One of them is parallel, and the other is perpendicular to the longitudinal axis of the petrous apex. One of them affects external drum and middle. The other one affects the inner ear and the facial nerve trunk. One of them is manifested by laceration of the external district canal, bloody otorrhea, tympanic membrane rupture or tears, CSF otorrhea. On the other one, the otoscopic examination is clearly free. Commonly, we have a conductive deficit in longitudinal and sensory neural in the transverse. Vertigo is absent in longitudinal and is present in transverse. Facial nerve palsy is rare in longitudinal and is common in transverse. Temporal bone fracture. Management of temporal bone fracture. Anti-shock measures. Prophylactic antibiotics. No water or drops per ear. CSF leaks normally closes spontaneously in 7 to 10 days with bed rest and avoid straining. But otherwise, if it doesn't close, this needs to be repaired with fasciolata. Ossiculoplasty for ossicular disconnection for conductive hearing loss or hearing aid for sensory hearing loss. Labyrinthine sedatives for vertigo until the patient gets compensation. Facial paralysis. If it is immediate and complete, this patient will need exploration and decompression. If it is delayed or partial, this patient will need conservative treatment in form of steroid and vasodilators. Noise trauma. Very common in blast injury and or chronic noise trauma as in factories. It causes atrophy of the hair cells, which may cause transient or permanent sensory hearing loss. We try to avoid them rather than treat them, so we try to avoid them by using earplugs, and if they happens, we normally treat them with hearing aids. Perilimb fistula commonly happens spontaneously due to straining and might happen iatrogenically by surgical trauma during a stapedectomy. Normally, it manifests with sudden and fluctuant sensory hearing loss, tinnitus, and vertigo. Fistula sign might be positive. We normally tend to treat them conservatively as a spontaneous healing normally happens. However, if they persist, we need to explore and surgically close the perilimb fistula. Surgical trauma might happen during removal of cholesteatoma or granulation tissue over the round or oval window, excessive manipulation of stapes during stapedotomy, contact of rotating pairs to the ossicles, or local application of ototoxic drugs as alcohol and saffron during surgery. Hearing loss has so many different causes. One of them is familial progressive sensory hearing loss, which is progressive sensory hearing loss which affect young adult with positive family history of consanguinity, and audiogram normally reveal bilateral symmetrical sloping curve. Treatment is a hearing aid. Presbycusis is a bilateral symmetrical sensory hearing loss associated with tinnitus, and decreased speech discrimination normally happens with elderly. So presbycusis clearly means age-related hearing loss, which normally happens due to degeneration of the in the organ of Corti, and it is age-related, and it is very common above age of 60. So 1 out of 3 people above 60 years old will have a presbycusis in variable amounts. So not all of them will need a hearing aid, but some of them will need a hearing aid. So they normally treat presbycusis with hearing aid. So benign paroxysmal positional vertigo is one of the common conditions which happens due to presence of copulolithiasis, which means gravels or debris inside the fluid of the semicircular canals, and it commonly happens in the posterior semicircular canals, and they normally manifest as a sudden attack of vertigo for less than 1 minute, and it happens on moving the head, usually posteriorly, and they are fatigable. Fatigable means that if you repeat the same movement, they normally doesn't happen. So they happen first time, second time, but third times it doesn't happen. And we normally diagnose them with what we call Dixie-Hall-Pike maneuver, which is a positional maneuver, which we will show it in the second slide. And we normally treat them with what we call labyrinthine sedative and Ebley maneuver. So here is a Dix-Hall-Pike maneuver, in which the patient will have to first sit in the bed, and then we allow them to fall suddenly with a 45-degree direction to one of the sides. If he shows any nystagmus or he feels any vertigo, then we need to allow them first for 2 minutes, and then to turn the head to the other side for another 2 minutes, which is a diagnostic for benign positional paroxysmal vertigo, and then here comes the Epley maneuver, in which you allow patient to sit in bed and to allow the same positioning of the Dixie pike for 2 minutes first, and then you will turn the head towards the other side for another 2 minutes, and then you will allow the patient to sit on his side for another 2 minutes, and then you will allow the patient to sit down with the head tilted 45 degrees for another 2 minutes. And this Epley maneuver normally cures most types of benign positional vertigo even without labyrinthine sedatives. The last disease is the most common inner ear disease, is the Meniere's disease, which, by the way, is a French otologist which has discovered this disease. So Meniere's disease is paroxysmal attacks of vertigo, tinnitus, sensorineural hearing loss, and oral fullness. So this complex symptom complex normally happens all together, or sometimes the patient having 1 or 2 symptoms. And this symptom happens due to increased volume of the endolymph, what we call endolymphatic hydrops. So why is the volume of the endolymph increases? We doesn't know for sure why in this patient, but we have so many different theories to explain. So first of all is the hypoabsorption theory, in which the obstructed drainage of the endolymphatic duct and sac will allow the fluid to collect and cause these symptoms, or the hypersecretion from stria vascularis, which might happen due to vascular ischemia, disturbed salt and water mechanics, local allergy in inner ear, autoimmune, and genetic factors, and that's it. When it comes to symptoms, those patients are having paroxysmal attacks of sudden vertigo lasting minutes to hours, tinnitus, fluctuating reversible sensory hearing loss, and this hearing loss normally affects low frequencies in early patient, and then if later on the disease, they normally affect all frequencies, and those patients are normally quite scared to be exposed to loud sound, and they normally go to scared to go to wedding parties, funerals, and this kind of things, because they normally experience very loud sound and they got scared from the loud sounds later on. And the last symptom, which is ear fullness. When it comes to examination, we don't have any positive signs in examining this patient. We need to ideologically evaluate them to discover any sensorineural hearing loss on audiograms, and electrocochleography is normally diagnostic for this patient. And in terms of differential diagnosis for Meniere's disease, we have 4 different diseases that has to be that we have to differentiate from the Meniere's disease. So all of them cause vertigo with fluctuant hearing loss. So first of all is the labyrinthine fistula, in which is a fistula between inner and the middle ear. This patient normally experiences vertigo and fluctuant hearing loss. Basilar artery migraine with a vertiginous aura. The headache is dominant symptom in the migraine, but not in Meniere's disease. Vestibular neuronitis, in which there is no hearing loss and there is no tinnitus. Epilepsy, which is having loss of consciousness, which is quite common characteristic symptom. Treatment of Meniere's disease, medical treatment is the main treatment to almost most of the patient. We normally give them antivertiginous labyrinthine sedative as Dramamine, Sinorezine, salt restrictions, vasodilator as beta-histidine, diuretics, corticosteroids, and minor tranquilizers. If the medical treatment fails to control the attack and the patient is having serviceable hearing, which means this patient is still having a residual hearing, so we do endolymphatic sac decompression with mastoid or subarachnoid shunt. So we allow the excess tympanic fluid or the endolymph to be diverted to either the mastoid process and absorb it, or the subarachnoid space to be connected with the CSF. And the second operation, what we call vestibular neuronectomy, in which we identify the vestibular nerve from the cochlear nerve, and we do cut the nerve on one side or both sides. If the patient is having unserviceable hearing, which is there is no residual hearing, then we do labyrinthectomy operation, which is surgical destruction of the labyrinth, or chemical destruction of the labyrinth using local gentamicin or systemic streptomycin. And that's all for the inner ear diseases, and I wish that you did really enjoy these lectures, and I'm waiting for all your comments, all your questions in the comment section. Feel free to ask any questions if you need, and thank you very much for your attention.